Hello and welcome to today's webinar, co-sponsored by the Center for Healthcare Strategies and the National Center for Complex Health and Social Needs, made possible by the Kaiser Permanente Community Benefit on Beyond Cost and Utilization, Rethinking Evaluation Strategies for Complex Care Programs. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on CHCS and the National Center's websites. We'll share links to follow-up materials. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Allison Hamlin, Senior Vice President at the Center for Healthcare Strategies.
Thank you very much, and welcome to all of you, and thank you for joining us today for a really exciting conversation with some of the leading thinkers in complex care around the country around some issues associated with evaluation and making the business case for these programs that are really critical to sustainability and continued growth of this field. I'd like to take another moment to thank our partners at Kaiser Permanente Community Health for making today's event possible and for sponsoring the Complex Care Innovation Lab, which is a signature initiative here at the Center for Healthcare Strategies that aims to advance complex care by bringing together leading national innovators across the country to work together to advance evidence-based approaches for building, operating, and evaluating these programs, and to foster policy recommendations to sustain these models and to spur new approaches. I'd also like to thank our colleagues and friends at the National Center for Complex Health and Social Needs for co-sponsoring this event today. We are really thrilled to help put on the inaugural webinar under the National Center's Policy Committee, and look forward to hearing Natasha Rosario talk a bit more about the National Center's work in this area in just a moment. Today's event intends to share and highlight themes that were developed through a set of 3 papers that were released last year through the Complex Care Innovation Lab, one which was published as a Catalyst feature in the New England Journal, and 2 that were published and disseminated as CHCS briefs, all of which fall under a theme of best practices for evaluating complex care programs and key considerations to advance how we think about evaluation of this field. And again, we are thrilled to have authors of these papers with us today to share their ideas in this forum. Now I want to take a moment to hand the microphone over to my colleague Natasha Rosario from the National Center. Natasha is the Associate Counsel and Senior Director of External Affairs for the Camden Coalition of Healthcare Providers and the National Center. And Natasha has some welcoming remarks from the Center's perspective to bring to us today.
Thank you so much, Allison. It's great to be here this afternoon, and good afternoon to you all. Just a little bit about the National Center for Complex Health and Social Needs. The National Center is an initiative of the Camden Coalition of Healthcare Providers. It was launched in 2016, and it aims to improve outcomes for patients with complex medical, psychological, and social needs and coalesce the emerging field of complex care. So as part of the National Center, we have the Policy Committee, which collaborates with other experts across the nation to inform policy, educate stakeholders, and create a shared language and strategy to help advance the field and build momentum for policy change. So if you can go to the next slide. So evaluation is really the foundation of a lot of policy and advocacy, and we thought it was really important, this is our inaugural webinar, to focus on evaluation for a couple of reasons. So one, with 4-year election cycles, policymakers can be hyper-focused solely on cost and utilization, overlooking a lot of other important metrics of success. So some of these could be quality of life, patient-reported outcomes, utilization of social services, and a lot of my colleagues on this webinar are going to go into more depth about those. 2, evaluation is critical to advocates making the larger business case for complex care. Advocates can't even get into the door of a legislator or governor's office, often without this information. 3, advocates need to discuss the challenges of evaluating complex care interventions. So some of these challenges include it takes time, it requires looking beyond dollars, and it requires linking different data sets from different sectors. Again, some of my colleagues are going to go into this. And 4, policymakers who are champions for complex care will have a broadened understanding of what success looks like. This is our hope, right? And this will lead to a shared language of evaluation, increased opportunities for funding and policy change, integration of successful interventions into the broader delivery system, and ultimately a stronger field and movement in complex care. So that's just a little bit of the policy context. I'm going to hand it back to Allison.
Thank you so much, Natasha, for laying that out. And it's an ambitious agenda, but I feel like we have the right people here with us today to help answer some of these questions and to get the dialogue going. So with that, it's my pleasure to introduce our speaker lineup today. In addition to myself and Natasha, whom you've already heard from, we are really thrilled to have Toyin Ajayi, who is Chief Health Officer for City Block Health, Maria Raven, who is Associate Professor in the Department of Emergency Medicine at the University of California at San Francisco, and David Labby, Health Strategy Advisor for Health Share of Oregon. And you'll be hearing from all of them in just a moment. So to lay out our agenda for the presentations today, as I mentioned, we are going to feature key themes from the set of 3 papers highlighted earlier. The first paper that Toyin and Maria are going to address provides the context for why we really need to go beyond traditional evaluation models for complex care programs, and they will suggest opportunities for doing so. I will then present from some of the key themes from a CHCS paper last year, going into a little bit more detail on the various limitations of using only a cost and utilization lens and some key considerations to think about when we interpret these findings from complex care programs. And finally, David Labby is going to present an alternative approach that really accounts for the emerging state of the field of complex care and the growing knowledge base in this field, using more of a research and development framework as we think about evaluation of complex care. So with that, and without further ado, it's my pleasure now to turn to Toyin and Maria for their first presentation, and Maria Raven will kick things off for us.
Great. Hi, thanks for having us. And we're excited to talk about this piece that we wrote for, as Allison mentioned, the New England Journal Catalyst. And it was really designed to be sort of a thought piece on evaluation and how we can improve. So we can go to the next slide. So I think most people on the call probably understand that individuals with complex needs are quite a heterogeneous population. I think there used to be sort of a trend towards chronic disease-based management and trying to group folks into kind of buckets based on certain diseases or other things that affect them. But it turns out, so still high-risk populations are often identified using kind of crude but available parameters, right? So these are things that can be easily measured in administrative data. And so it makes it easier when you're doing an evaluation to focus on these sorts of things. So high acute care utilization. So often evaluations focus on, the frequency of emergency department use or inpatient utilization. Sometimes people are grouped according to their medical spend, looking at, the top decile, the top 5%, the top 1%. Sometimes based on a combination of multiple chronic diagnoses, both chronic disease and behavioral health conditions. And then sometimes folks are grouped based on their insurance status. And even when you do these groupings, the underlying contributors in every one of these groups really vary, right? So people can have all different combinations of chronic medical conditions, mental illness. Many people are affected by substance use disorders, and then really important social determinants of health like housing instability, an inability to work or live in a safe neighborhood, disability, trauma and adverse childhood events, and then things like poverty and really a lack of social networking that don't allow people to get the support that they need outside of the healthcare system. Next slide.
And so what this necessarily lends itself to is, as Maria described on the previous slide, we have the only commonality across these populations that we define as complex is the heterogeneity of their needs. And so what this lends itself to is that interventions designed to address populations with complex needs definitionally have multiple different levers that they're pulling on, and that are tailorable to individual communities, individual population-specific needs. And these are tailored for a whole host of reasons, including many of the ones that we described. And so what we find is that when we look across the landscape of programs that are designed to impact populations with complex needs, they look incredibly different. There are a few common features that we see across them, but they are differentially applied both from program to program, but also at the individual level. Some members may get social needs screening and referral, others may get housing support, others may get integrated behavioral health treatment, chronic disease management, home visits, care coordination and management. And the heterogeneity of the deployment of these interventions, both at the individual level as well as at the programmatic level, lends itself to some pretty significant challenges as we think about evaluation. Next slide, please.
And so, as Toyin was mentioning, this complexity of these interventions and the underlying populations that they're designed to serve really create unique evaluation challenges. So one, and a really important one, is the outcomes. So what outcomes do we focus on as evaluators and program implementers? And, you know, just as it can be easy to group certain populations because of what's available in sort of administrative data, like Medicaid data or data from your hospital, it's also easy to get at certain outcomes using those mechanisms. So really easy things to look at in the data are medical outcomes like utilization, expense, readmissions, and then costs. People like to talk about all the time a return on investment, which we'll talk about a little bit more later. But then there are really important other outcomes that can be really difficult to measure. And those would be societal outcomes, people's quality of life, and other ways that programs might be affecting them that might not necessarily have a direct outcome on some of these other things that are easy to measure, but that are really, really important when we're thinking about whether we should implement a program or not, or sustain it or not. Another really challenging thing about evaluating complex populations in the programs that serve them is that, you know, as Toyin mentioned, often even within a single program, an intervention will be tailored to specific patients really differently. So one patient may need durable medical equipment and may need a motorized wheelchair, and another one might need transportation to an appointment is another great example, whereas another person kind of has that covered, but they need housing placement. And so both those individuals in the same program might have a great outcome, but how do you compare those outcomes to one another when they're so different? And then the other thing that often comes up is because there are often so many components to interventions for complex populations, there are interventions that occur within the healthcare system, and then things that can occur out in the community via community-based case management or community partners. And it's difficult to understand, well, what part of this intervention is that part that is really leading to the outcomes that we're finding? Should we add, should we take away, or really is it hard to disaggregate and we just need to kind of take the program as a whole? And then finally, the time frame. So often, as I think Allison alluded to earlier, you know, or maybe somebody else, but you know, there's a 4-year election cycle, and it can feel really difficult to get policymakers the answers that they want. They want evidence really quickly, and for these kinds of populations, it can actually take quite some time to make an impact, create behavior change, find housing, all these sorts of things. And so it's difficult to look for success when you have a 12 to 18 month period of funding, for example, for an evaluation. Next slide.
So what we outlined in the paper that we'll go into in more detail is a set of principles that we would recommend to guide complex care evaluations. And we'll go into each one in more detail in the subsequent slides. But if you remember anything in terms of a high-level set of hopefully actionable principles, it would be these 3. So the first is we must allow adequate time to evaluate impact. The second is to look beyond dollars. Sorry, I'm just going to list those out. The second is to look beyond dollars, and we'll talk about that in more detail, and also look forward to hearing David Labby talk about his approach as well. We have to be mindful of other outcomes that we should be tracking and figuring out ways to roll those into overall value. And then the third is to link existing data sets to capture more comprehensive effects that allow us to account for the full scope of services that were accessed and impacted. So if we go to the next.
Yeah, so the first one, allowing adequate time. So a lot of interventions are launched, as I mentioned before, and that there's this expectation of realizing some kind of return on investment or other positive outcome over a short time frame. 3 years would actually be quite generous, frankly. Often evaluations are restricted to 12 months. I've seen some that have, certain papers that have been published looking kind of 6 months before or 6 months after. This is really difficult because as I mentioned earlier, engagement, behavior change, and kind of shifting the way people are using health services and other services, it takes time. That's not something that can change overnight, as do getting people the resources that they need. I know where I live in San Francisco, everyone can want someone to be placed into housing, but until a unit opens, you're really kind of working around that issue. And then customization, learning, and iteration of the program model takes time. So sometimes we implement programs and we say, I like this aspect, but this aspect isn't really working, and I kind of want to change up what we're doing. And those also impact outcomes in the time frame that you need, and you need to allow for that. And then often we're dealing with small numbers of patients or events or outcomes, and so it can require just a longer time frame in order to accumulate enough data. So we really feel that evaluations have to take a longer term view. And, it's okay. You can look at outcomes at a certain point, preliminarily, knowing that you really got to keep looking out over a longer horizon than 12 or 18 months.
As we think about then defining endpoints, we know we tend to fixate very much on that financial return on investment in that healthcare space, and specifically in healthcare dollars, because to sort of preempt a little bit the next point, we tend often to lack the ability to link financing sources and to link our evaluation across different types of funding sources. But we recognize that improving and prolonging the lives of some individuals with advanced chronic illness and disability may actually cost more money. Innovating in ways to improve outcomes for these populations may also cost more money, or that they may accrue savings in other non-medical domains. And here you can easily think of a number of examples. Think about saving the life of and improving the quality of care for somebody with advanced physical disability who then lives longer, actually in absolute terms. There's value there to the society. There's value to that individual's family, to the quality of life that they have achieved for themselves. It's very difficult to quantify that in financial terms on the type of time frame that we typically look at interventions on. And then we have to figure out a way somehow to understand and quantify savings that accrue elsewhere. If we're able to keep somebody home and employed as opposed to potentially involved in the criminal justice system, there's a cost saving at the societal level that doesn't accrue to the healthcare payer. It doesn't accrue to the healthcare dollar, but that does come someplace else, and we must be able to account for that. So we think about a whole host of other endpoints that come readily to mind. Quality of life, the value of patient-reported outcome measures. So perhaps we did not meaningfully decrease somebody's total cost of care, but we significantly improved their functioning and their sense of hope and optimism for their future, their ability to engage with their family and their loved ones. Perhaps we were not able to decrease the acute care hospitalizations for an individual, but we were able to decrease their use of the shelter system or their child's need for integrated supports at school because they actually had a parent who was healthy enough to support them and to take care of them. We talked about criminal justice involvement. We know that's an incredibly expensive part of our social services, if you could call that, delivery system, and that's an area in which any person that we're able to help reduce recidivism for accrues a savings to the rest of the system. And then the presence of and compliance with advanced directives. Here's where we're talking about some of these very, very difficult to quantify outcomes. What is the value of helping a person live and die in the way that they want to? Helping a person have a high quality experience at the end of their life. It's very difficult to account for that in financial terms, but clearly meaningful. And so we believe very strongly that we have to work together as a community to include, identify, to validate, and to share non-financial endpoints that are meaningful but otherwise difficult to value in terms of a dollar amount. Next slide, please.
Yeah, and so along the same lines, we also feel it's really important whenever possible to be able to link data sets when you're evaluating a program for complex individuals, because we know that people that are using the healthcare system frequently are also using a lot of other systems frequently, and this has really been borne out in the literature. So often, for example, frequent emergency department users will be the same people that are actually getting admitted to the hospital, using primary care, using community-based services, having criminal justice encounters, having encounters with the behavioral health system. And so if we can't capture all of this and we have kind of this myopic view focused only on health-related outcomes, it really can't take into account the effect of a program overall. And so, for example, I've done some work, and just to kind of show that this is possible, although it can be challenging, linking housing data with criminal justice system data, with use of the healthcare system, with use of the behavioral health system. There are other data sets also that would be really important to include depending on the population that you're focused on. So these would be education, other things related to various aspects of social welfare. And like I said, this is doable, but you really do have to take the time to build relationships, develop data use agreements and memorandums of understanding, and really make sure that you're working with your community and other maybe state agency partners to make sure that you're really all working towards the common good of an evaluation. And I feel like once everyone realizes they're on the same page and everyone kind of wants to figure out exactly the most accurate way to account for the full impact of a program, data sharing really can be possible. And so whenever possible, I think increasingly this is going to be a really important thing to look at when we're evaluating these types of programs.
Great. Well, this is Allison Hamblin from CHCS, and just want to thank Maria and Toyin again for kicking us off with such eloquence as we start this conversation. And to the point about linking data sets, I just want to highlight a concrete example of what can come of the education and learning opportunities that can come when that is successfully achieved. Another member of the Complex Care Innovation Lab is Hennepin Health in Minneapolis, Minnesota. And through the Innovation Lab, we were able to support a research study last year where Hennepin was able to bring together information and data from the healthcare system, from the criminal justice system, and from the housing systems. And we're able to really look at service utilization across those three sectors for what we traditionally think of as high utilizing healthcare patients or beneficiaries in our system or members, depending on what your perspective is. And to be able to get a more robust and comprehensive understanding of how individuals are moving throughout and across our systems is tremendously powerful and suggests many new opportunities for both intervention and partnership. And so I just wanted to highlight that as a case in practice of what Maria just alluded to, and we're happy to share a link to that study, and a follow-on study is forthcoming later this year as well. So thank you again to our first presenters, and I am going to take us through some of the highlights of the second paper in this series that was put out by my colleague, Rachel Davis, who would normally be presenting today, but she is on maternity leave at the moment. And her collaborator on this paper was Aya Ram, who at the time was Chief Transformation Officer at Commonwealth Care Alliance, another member of the Complex Care Innovation Lab, and who is currently a colleague of Toyin's at City Block Health. So we are all represented here in one way or another. And what I'd like to go through today is a bit of reinforcement of what you heard from Maria and Toyin, and a little more context about how complex care evaluations are currently being evaluated and discussed, and some of the concerns if we don't do something about that, and some of the limitations of those approaches. I suspect many of these themes will be reinforcing for many of you, but it's really important us to be mindful of how we are talking about this work and the expectations we are setting for the results they can generate. So what is the current state of complex care evaluation and outcomes data? As we've been describing, there is a very heavy reliance currently on cost and utilization data. By and large, that's what we report when we study these programs, and often that's what key stakeholders are asking for when they want to know, is that program effective, or what kind of outcomes did that program or this program generate? Cost and utilization is generally what is top of mind. However, as we've been discussing, these data are very difficult to interpret, and this is one of the messages we really want to convey through today's presentation. When we hear results being shared across programs, there is really a lack of standardized evaluation methodology in this field, and that's not for lack of effort or trying. In the world of complex care, it's difficult to implement the gold standard randomized controlled trial in many cases. It's difficult to construct a perfectly valid comparison group for one reason or another, or using one methodology or another. So there are some real limitations to our ability to use strong study design for these programs, and as a result, it can be difficult to interpret the results that are coming out of one program versus another. As others have mentioned before, it's also really hard to tease out what we're talking about when we say such and such program was effective or not effective, or generated this outcome or another, because these interventions are so multifaceted, as Maria described earlier in very articulate fashion. These interventions vary at both the individual level and at the program level. So even within a given program, the intervention that one individual is getting versus another can vary significantly, and I believe Toyin spoke to this as well. And finally, as others have said before, when we are looking at cost and utilization, we are really only capturing one small aspect of overall program impact. And as we talk about results, and as we talk about the outcomes of this work and what the expectations for this body of work is trying to achieve, it's really important that we broaden our language and we start talking and reinforce the notion that the impacts that these programs will have span a much broader realm than just healthcare cost and utilization. So if we don't, what are the risks? And I will say that this is, for me, one of my slides of what's keeping me up at night as it relates to the field of complex care. When we set the expectations that these programs will save money in short time frames, what are we running the risk of? Well, there's probably a lot of them, but I've listed some of them here. We risk prematurely pulling funding from programs that likely work well. And many of us have examples of this. There are war stories of various kinds that we could share. But if we have promised, or there's a set of expectations that these programs will achieve certain cost and utilization results in a 1 to 2 year time frame, and that doesn't bear out in the data, we really run the risk that the funding for these programs are not renewed when in actuality there may be very good and important things going on and very powerful outcomes being generated. The flip side of that is we may inappropriately spread programs that don't work. So we may, by nature of how a study was evaluated, perhaps there isn't a strong study design behind it, but the headline results are really powerful and attractive. This program saves $6 for every dollar invested. Well, that's got appeal, and that's something that many folks, whether it's at the policymaker level, at the CEO or CFO level, that can be a quite attractive proposition if we can generate those types of cost savings. And that may lead to programs that frankly aren't that well understood or well defined, or perhaps not as impactful as they might seem to be, getting replicated when we really don't know exactly what we're spreading. And finally, we are likely missing opportunities for continued investment in the learning that is an ongoing aspect of complex care work right now, and missing opportunities to sustain programs that, as others have noted, might be generating some impacts in the healthcare sector and other impacts in other sectors, whether it's criminal justice, education, housing, what have you. So why do we do this? If we're pointing out all the limitations and holes in the notion of using cost and utilization, why do we do this? And again, many of you are familiar with this. Well, as Maria described, it's aligned with the defined problem. We often identify folks for these programs based on high cost and utilization, and so it makes sense to look at whether or not we are improving those outcomes that were the cause for folks to be entered into these programs to begin with. Cost and utilization outcomes are also currently the gold standard for assessing any care coordination programs. If we are providing more coordinated care across systems, we should see reductions in avoidable utilization, and so it does make sense to measure that. As others have mentioned, these data are readily available, particularly on the healthcare side, particularly when payers are involved. The measures are familiar to many of us in the healthcare realm. They're easy to understand. And this last point is important, and the complex care field has benefited tremendously from the bipartisan appeal for cost containment that these programs promise. In all states around the country, programs that are targeting high utilizers have benefited from support across both aisles, recognizing this is an opportunity to improve outcomes for folks who have not been served well in these programs and have the potential to generate meaningful savings to the healthcare system. And that appeal sort of is a double-edged sword because it has gotten these programs initial investment, but it also is the threat looming over this field if programs can't deliver on expectations that have been set. So what are the limitations? And again, some of this is reinforcement from what others have said, but with these programs, overall, we may want to reduce avoidable utilization and bring down outlier levels of healthcare costs. But in any given case, we are looking to increase connectivity to outpatient care, to get folks a solid primary care home, for example, to increase access to behavioral health treatment for folks who have unmet mental health or substance use disorder treatment needs. And so the notion of just looking for a net change in utilization masks many more specific changes in utilization that may actually be benefits and good outcomes for the individuals that we're serving in these programs. Secondly, and this is something we don't talk about enough in this work, but when we're looking at cost, we are really masking the role of price as a cost driver. And so if we're looking at overall change in total cost of care for a population served in a complex care program, we really need to understand what is the role of price in influencing the trend and influencing that outcome. And it's really something that's not on the table or talked about very much, and certainly as we are comparing impacts over time and impacts across systems, it is a very relevant factor to consider. Others have talked about the time frame, so I won't delve further there. We've also talked about the need to capture savings outside the healthcare system. The next one, accessing comprehensive data, is, again, a really important limitation. And so in some cases, programs are being evaluated at the health system level, and it can be very difficult at the health system level to capture utilization outside that health system. And as many of us know, many of the individuals served in these programs use multiple healthcare systems. So they may visit an emergency department in another system or have an inpatient admission in another system. And it can be very, very difficult, despite best efforts, for one healthcare system to access that other data and to capture that in their evaluation. At the payer level, we run the risk of not including what the payer is not responsible for paying for. And again, particularly as it relates to behavioral health, where we can't measure changes in behavioral health service utilization. If a given health plan, for example, does not cover those services, we're really missing an important part of the picture. Accounting for regression to the mean, again, I think is a familiar challenge to many folks, given, again, that we are generally talking about the flatter part of the bell curve or the outliers in a distribution of healthcare users. And again, the important thing to note here is really in terms of interpreting results that are shared and disseminated to make sure we can really understand and translate what role regression to the mean plays in those results, particularly if those results are creating expectations for other programs that are difficult to match. Acknowledging regional variation, again, is tremendously important as we think about interpreting results from one study and using them to set expectations for outcomes that may be achieved in another region. As many of us learned from the work of the Dartmouth Atlas, there is tremendous variation from region to region, even within a state, on baseline levels of utilization, depending on the nature of the healthcare landscape in a given geography. And therefore, it's just as likely that changes in healthcare utilization would vary, and our expectations for the degree of changes that may be realistic to expect would vary in one region to another, just based on, again, the baseline levels of healthcare utilization and the nature of healthcare system use in one region versus another. And so again, as we look to learn from studies in one part of the country or one part of the state, and apply them to set expectations for another, we do so at some peril that it may be unrealistic and an inappropriate comparison, again, based on the nature of the local environment. And others have talked about the limitations of using kind of these blunt measures of cost and utilization to have any sense of what's actually working in the context of multifaceted interventions. And so lastly, I just want to, again, reinforce some of the notions that Toyin and Maria have already shared about the importance of establishing realistic expectations. And for those of us who work in this field, we are critical actors in adapting how we talk about evaluating complex care programs to be part of the evolution of moving the discussion of outcomes in this field to a more comprehensive range that gets beyond the more narrower view that we've been describing. David is going to talk in a moment about how we might think about really using evaluation frameworks as a learning system, not just thinking about endpoints and results, but really using evaluation to guide the ongoing knowledge base and development of this field. Toyin and Maria have spoken beautifully about other measures that we should really be considering in this work, including housing stability, employment status, reduction in social isolation, and measures of community engagement, among others. These are really meaningful impacts that these programs are having. And in some cases, those outcomes are best told through stories. And we're talking today about data and quantitative evaluations, but we should all be mindful of the power of stories to complement what we can show through data. There's just nothing more powerful than hearing Maria and Toyin and David talk about the actual lives of individuals that they've touched. And it really brings this work alive. And policymakers and CEOs and CFOs are just as likely to absorb the power of those stories, and legislators, what have you. So I would just encourage folks to continue gathering those stories as a complement to the data. With that, I'm going to go back to my moderator facilitator role and turn now to David Labby, who's going to talk about using a research and development framework to support complex care program design. This is going to take us more to forward-looking, thinking about instead of the status quo, how might we think about evaluating complex care programs in a different light? And so with that, David, we will turn it over to you.
Thanks, Allison. So this brief was really created out of the frustration of dealing with all the issues that you've heard about, and being someone who over a couple decades has tried to build program after program and always dealing with CEOs, stakeholders in various forums saying, show me the results, you know, is this working? And really, I think what comes back to the realization that in terms of the working around complex care, we're very early in this process. Jeff Brenner, one of the founders of this field, probably known to most of you, brings up this point repeatedly. And at one point I heard him say, you know, we're sort of in the bloodletting phase of this. We're just doing the really early, probably things that we will know later on don't really work, but we're just starting out. And I think that's really important. But that's a huge shift in terms of the language that we use in talking to our stakeholders and setting expectations. Allison mentioned setting appropriate expectations, and that's really, I think, the essence of our work right now. Clearly, there are some simple things that we can do in dealing with relatively complex issues. There are programs, very simple, very focused programs that might work, but most of what we do as we deal in the deep end of complexity are really complex, are really complicated, and we need to educate the people who are supporting us in doing this kind of work that they are on the same learning journey we are in terms of population health, in terms of understanding social determinants of health. 20 years ago, people were not really talking in healthcare about social determinants of health. 10 years ago, they weren't really talking about social determinants of health. In my experience, it was only with the triple aim when people started saying, well, community health is one of the outcomes. People began to talk about, well, what does that mean? And we got deeper and deeper into thinking about what complex care means. So, thinking about the mental model that we currently operate on in healthcare, it's a very simple mental model. I mean, healthcare, what is the evidence? We need scientifically proven results. We use that for drugs appropriately. We use that for surgeries, interventions, technology appropriately. A lot of health plan benefits are based on that. Is there evidence for this? Has this drug been proven? Do we put it in the formulary or not? In fact, that's probably vastly simplistic in terms of what we're dealing with. Plus, it also underestimates what it takes to develop a drug. If you think about a drug is put on the market after years and sometimes decades of development. We don't talk about that. We go to our stakeholders and organizations with a plan for a program, and as Maria said, they're expecting us to come up with proven results by some method in a year, in 3 years. No, there's very few drugs that have ever been developed that fast. It would be a miracle. Very few interventions, technological interventions. So we need to sort of help people understand that the work that we're doing is really the research and development part of understanding the non-medical needs, the non-clinical needs of the population that we're dealing, which are such big drivers of the outcomes that we are looking for. So talking about this, these are research and development. This is the way we, as the program leaders, and us as the organization, is going to really learn to understand our population in a much broader context, and setting that as the expectation. There is sort of an engineering viewpoint that people have to this. Next slide, please. And I use this because in 2015, a number of years ago, we received one of the first CMMI grants to do a 3-year project. This involved multiple stakeholders across the region in the Portland, Oregon area, multiple organizations. It was a very complicated project involving primary care, specialty care, hospitals, EMTs, and on and on and on. And when the administrative executive who was sort of in charge of the budget for this was presenting it to the board of directors of our organization, she got up and she basically said, we're going to test all of this, and in a year we will tell you what works and what doesn't work, and we will then decide what we do, and the things that work we will do more of, and the things that don't work we will quit doing. It was sort of like, and it reminded me of this sort of engineering. Does it move? Should it move? Well, if it should move and it doesn't move, let's squirt it with WD-40, and if it shouldn't move and it does move, let's put some duct tape on it. Very simplistic kind of thing, and that was not at all the experience. And we spent several years re-educating the board, a lot through stories, and a lot through helping them understand what actually we were dealing with and the complexity of the problem. So the next slide sort of talks about a way of thinking about and sort of codifies the experience I have had in dealing and building programs over several decades. And what is really, and we don't talk about what it's like to build a program. And actually, I don't know if there's even a literature that has actually looked at what is it like to build a program that deals with complex patients. How long does it take? What is the experience of people in the field? We just have adopted. I think we're in a certain sense guilty ourselves because we just sort of adopted a simplistic evaluation framework, but that's not really, it doesn't apply, as you've heard by the previous speakers, to what we're doing, but we really haven't put in its place any other kind of model. So this is just again, a thought piece to thinking about, well, what does this work really look like? So I propose that it has something like 4 phases. They get kind of mixed up in a way: prototyping, testing, optimizing, and sustaining. And I'll talk about each one of these. But it isn't just we have this great idea. We're gonna put it out there for a year and try it. We're gonna evaluate it and tell you in even 2 years or even maybe in 3 years if it works or not. The next slide first, please. So the prototyping phase, which is sort of the first phase, really starts, if you really want to start with the beginnings of it, is really understanding what's important to your stakeholders. I think it's great to have a good idea, but unless the good idea that you have is important to the people who have the resources to make it happen, you're probably not going to get your good idea off the ground. So really understanding, what's important to your stakeholders, what problem we are trying to solve, and your stakeholders, are lots of stakeholders. They're not only the people with money, but they're your consumers, your providers, et cetera. And do we really understand the major drivers of the problem that we're trying to solve? There's lots of, our experience over the last 5 or 10 years around transitions in care has been really interesting, because we started out with thinking it was sort of a care coordination problem. Well, I can remember the early conversations. Well, the letters, the discharge summary isn't getting to the primary care provider fast enough. Or, the specialty referral isn't followed by a good enough letter. It's just a matter of coordinating the care within the medical system. That's not the underlying drivers of a lot of the problems around transitions in care, whether it's transition from hospital, from specialty to primary care and back. There are many more issues. And so the more that we understand those underlying drivers, the more we can actually build a program that will be able to address them. And of course, that gets to the issue of what can we actually do about these drivers? Maria mentioned the housing issue. I think it's a great example, because you can have a perfect program that works in community A that has access to housing resources, and the program is really dependent on those housing resources. You can write that up, you can put it in the New England Journal and get it published, but it may not work in community B because they have no housing resources, and the program is really about what's happening in the community and not what's happening in the healthcare system. So part of the problem is, do we have within our system or partnerships with others that we can actually address this problem that we've identified, this set of problems? Where's the best place for the program? Does this belong in primary care? Does it belong to a standalone program? Is it central? What kinds of staff? We went through a huge conversation about, we want to do a community-based program, really reaching out to people in the community. Well, who reaches out? Is it social workers? Is it nurse practitioners? Is it peers? Is it a combination of all those things? So it all comes down to really understanding the problem, figuring out what resources you have and what resources you need if you're going to be effective. And of course, who are the people who have to buy in locally in your organization or in the community to make this work? So this is all stuff that you have to do before you start. And that, I think, is sort of setting up the prototype. And then the next step, in the next slide, is really testing this. So you can come up with a great idea, you can have all the pieces together. But we found that our great idea, figured out by a group of really smart people who really understand the population, may not be seen as a good idea in different contexts, may not be seen as a good idea in a primary care practice who hasn't gone on the journey that we have, and in fact has no bandwidth for dealing with what we're trying to deal with, and they may or may not be the best place. Maybe the best place we found for some programs is actually in the community, in homeless shelters, et cetera. Is that something that they think works for them? And once you get it there, once you get all the pieces moving, is it actually working as they expect, as you expect? How does it work? How does it work for patients? How does it work for their staff? What do we need to change, et cetera, et cetera? And how are we communicating all of this back to our stakeholders? Because part of this learning journey is for them to understand what you're understanding and we are understanding about the community that we're serving and the population that we're serving specifically. At this point, we found that stories were really, really important. They totally changed the way our board of directors, who we reported to on a regular basis, thought about this quote unquote high utilizer population. And we ceased to talk about them as high utilizer fairly early on because the utilization wasn't really the root cause. And so just the proof of concept in this learning journey gets everybody on board of trying to understand what problems how we can solve the problems that are actually causing us pain and causing the community we service pain. Next phase. The next slide, please. So program optimization. This is something I put as a phase, but actually it goes on all the time. It's the question that Maria and Toyin raised. Your population is heterogeneous. some parts of the population need housing. Some parts of the population need mental health or engagement around substance use disorders. All of these populations, it's a heterogeneous population. And so what we found early on was talking about the population not as simply, this is our care coordinator or complex care population, but what are the subgroups? And we even began to talk about archetypes. What does it look like when we encounter somebody who really does well with our program? What are the characteristics of that kind of person? Are there other kinds of people like that, so that we can focus on some subpart of this, and maybe even focus in on what we do really well that works? And on the opposite side of that, who do we encounter that we try and help that we just don't get anywhere with when we're working harder than they are? And why is that? Those conversations as you go along are not only useful for program development, but they're really useful for supervisors who are supervising your staff to say, you know, we've been working too hard with this particular individual, this kind of individual. We need to step back because they're not ready for us and we're not ready for them. Those kinds of things allow you to sort of focus in on the subpopulations. And in truth, evaluation may be more effective the more that we focus in on a controllable set of variables. You know, most of the evidence is created in studies that limit the amount of variables. When we take a complex population and we don't break it down into sort of subgroups, we make that virtually impossible, as has already been referred to. So part of program optimization is thinking about, are there themes, are there archetypes, are there subpopulations within our group that we can focus on, we can enhance our programs, and maybe there's a series of sub-programs that we're actually running on unaware of, that we should focus on, and we should evaluate them individually. Again, going back to our stakeholders and educating them as well. Next slide, please. And of course, I think I made this as phase 4, but this goes on all the time. How do we make the case to stakeholders about that they're better off with a program than without it? I think that actually starts on day one. And it really depends on your ability to engage your key stakeholders and their ability to take it to the larger organization about what you're learning from your organization, from this project, and what kinds of returns are actually happening, not only in your organization, but elsewhere in the community. I mean, others have talked about the possible benefits in terms of criminal justice. To go into most healthcare organizations and say, you know, we could create this great program that's going to decrease recidivism in the criminal justice system, that's probably not going to get funded right out of the gate. That may not be seen as an important issue for the healthcare system to focus on. However, as you go forward and you learn that, as we did, that over 50% of our population of high utilizers actually is high utilizers in the criminal justice system, and you can look at them as high utilizers of healthcare and or high utilizers of the criminal justice system. And in fact, a partnership with the criminal justice system is probably one of the smartest things that we can create. But that's a learning journey that you're going to have to take people with you on. And then that opens up the question about, well, yes, that's really interesting. How would we look at data in terms of savings in the criminal justice system, recidivism, things that we act when people fail in the criminal justice system and they get discharged, they end up on our dime. So how do we think of this in a much more holistic way? But I think those conversations have to start early. If you're going to actually create learning within your organization, you're going to have those, tell those stories, raise those issues from the beginning, and get people to go on the same journey that you're going on as you learn. Next slide, please. I put this in here because I think one of the traps we get ourselves in is that we sell our stakeholders that we're going to do something, and we get into this idea of, we agreed that we're going to do this, and the question becomes, are we doing that right? We agreed that we would put so many social workers in XYZ places, practices, et cetera, and increase caseloads, and we just get focused on those kinds of numbers. But a guy named Chris Argyle created this concept of double loop learning, and the second loop is, are we doing the right thing? Is this really what we should be doing? And as we learn about the population, is this program that we initially set up the program that we actually need? From our experience was we changed our program hugely over the course of the 3 years that it had funding. And we continue to change it because that question of are we doing the right thing becomes more and more salient. In the beginning, when we started this program, there was no way our partners in the healthcare world would at all even talk about housing. Several years ago now, the healthcare systems in the area have all invested in supported housing. So that was a journey we went on with them, partly because we were bringing back to them the learnings of the journey that we were on. And finally, the last slide. Now, I think just go click through all that. Yeah, next slide, please. So I think we really need to change the mental model in terms of population, what it means to do population health. I don't think population health is going to be the same kind of activity as developing a drug. It may have similarities in terms that it's going to take a long time, that we're going to have a research and development process, but I think the simple evaluations and very narrow abilities to evaluate a given intervention are not going to be available to us. And I would actually propose that that's not really the way the healthcare system operates in any case. Having been in this for a number of years, I have not ever seen a large-scale program developed because of evidence. If you take the chronic disease model that came out early on, if you take the primary care medical home that is now developed, the evidence base for those things, which are now fairly standard concepts in healthcare, is fairly scant. But we do them because we understand, we as human beings can understand the complexity of the situation. We understand that when something isn't working, there's an urgency to fix it. And we get enough sense of what might fix it that we're willing to go out and try something that makes more sense. The shift to individual-based primary care, which is the old expert medical provider model, to a team-based model was so intuitive to people that it is now, I believe, pretty much the standard of care in primary care. It's very hard to think about primary care now without thinking about a team-based model. That didn't happen because of evidence. That happened because we created a collective narrative about primary care. We created a sense of urgency that it needed to change. We put out there that there certainly is a potential for return on investment, but that return on investment, as Allison has defined, is much more complex than simply dollars and cents, although that is part of it. So I think part of this for us is not simply adhering to old models of evaluation of randomized controlled trials, but to reframe what we're doing in a way that says, look, as Jeff Brenner said, we're early at learning how to do not only complex care, but population health. If you're serious about going on this journey, which you really have to be if you're accountable for population health in any kind of accountable care way, there's a lot for you to learn and for us to learn, and we can engage with you. And there's things we will learn along our way around the population we serve, around what we need to do to change our systems, and how we can create partnerships with others to get the better kinds of outcomes that we're all looking for. So I'll leave it at that. Just to sort of say, this is one way of thinking about it, but I think we need to open up the conversations about evaluation and not just feel that we are failing if we can't come up with a randomized controlled trial, if we can't come up with a perfect propensity match, which I believe is really challenging, or simple data points that show that we are being wildly successful. And that's going to come because we have created a new engagement with our stakeholders. And I think it's up to us, those of us who are leaders and advocates in this field, to have those conversations with the healthcare system. Thank you.
David, thank you so much. This is Allison, and as expected, I think you've got us all. Our minds are expanding as we think about the implications of what you just presented and how to take them forward in our respective organizations. So really appreciate you putting a stake in the ground and laying out one framework for doing so based on your experience at HealthShare of Oregon. So thank you for that. We are at the point in the presentation where we are going to be conducting a Q&A session with our presenters. Thank you to those of you who have been submitting questions as we've gone along here. For those of you who have a question and have not yet submitted, please refer to the instructions on the slide in front of you, finding the Q&A icon located at the bottom of your screen, and sharing your thoughts with us. And I anticipate we won't get to every question, but we will do our best, and to the extent we can follow up with presenters after the webinar, we will endeavor to do that as well. We do have some questions that we at CHCS have prepared for some of the presenters, and we will start with a few of those. Toyin, the first question is for you. And in light of everything we've heard thus far in the presentations and David's ideas about an R&D framework, I'm curious how you think complex care programs can balance this desire to be nimble and fail fast with the longer-term nature of these types of evaluation.
Sure. I think that there's a couple of ways to approach this. One is the notion that that there are some things that we where the evidence base is relatively strong, and so care coordination, integrated care teams, behavioral health integration in those care teams, social determinant screening and referral to services. Those are things that we have pretty good evidence in certain circumstances that should be applied across. So it's not like, while we are, I completely agree with David that we are very, very early in this process of understanding what works and doesn't work. We're not starting it completely from scratch. And so starting with the idea that there are components of every program that have a stronger evidence base than others, then we need to structure the way that we innovate such that we are, to the question prompt, really being nimble and failing fast and learning quickly. And there's where I think a much more quality improvement type of infrastructure is helpful. So we have a whole host of frameworks that we could draw upon, the PDSA cycle, things like that, that allow us to say iteratively, how do we very quickly refine aspects of our model to understand whether or not they're effective. I would strongly, however, urge us away from saying we're expecting to find enough outcomes in a short enough amount of time, so in 12 months, as we discussed, such that we would be able to discard an idea or an intervention as not working. We need to give them the time to work. If we start from a set of hypotheses and we build out a logical framework, which with evidence-based steps along the way, even if the entire program itself doesn't have strong evidence behind it, then we've got to give each step the time it needs to prove their outcomes out, and we have to be really structured about that. And frankly, we have to be pretty disciplined about not pivoting too frequently before we've allowed our interventions to have a chance to really come to maturity. And so separating both of those out, I would say in summary, really thinking about rapid cycle innovation around iterations to models, around specific aspects of like how you might deploy an intervention, how you might think about outreach or engagement. Components of that model, I think we should be very, very, very keen and very structured in the way that we promote rapid cycle learning. But if overarchingly we have a program, for example, whose goal it is to reduce healthcare expenditures and recidivism and improve quality of care for people recently returned out of incarceration, out of engagement with the criminal justice system, we've got to be really diligent to say, we think it's going to take 6 months in order to find people, another 12 months in order to engage them and build trust, another 12 months beyond that to improve folks' health literacy and understanding such that we're starting to change their utilization patterns. Therefore, we're going to stay the course and we're going to actually test this out over the course of 36 months. I think we have to do that despite the pressures to quickly show savings along the process.
Thanks so much, Toyin. On a similar vein, Maria, a question for you, and I will out you as the health services researcher of the bunch. Given everything we've been talking about in this presentation, where do you see the role of randomized controlled trials in this field? Is there a role, and how do you contextualize that given all of the challenges that we've been describing?
Yeah, it's a great question. I think certainly randomized controlled trials are sort of viewed, I think, both as the gold standard and as potentially a real pain that can hinder evaluation. I think people often feel that they are untenable, impossible, they require a lot of resources. So I think you have to decide with your organization sort of what you care about. So I think if you say to yourself as an organization, you know what, we just want to make sure that we are covering program costs. And so that when we look at how we're doing over some number of years, as long as we don't, as long as our population, for example, as long as our program doesn't cost more than changes we're seeing in healthcare utilization and we kind of break even and we feel like we're doing the right thing, then that's enough for us. And because we know we're doing the right thing for this patient population, either by offering them community-based case managers or health system-based case management or other interventions that sort of have been shown, at least preliminarily, to be potentially effective, then you may not need a randomized controlled trial. But if you're an organization that really is concerned about issues like regression to the mean, and you really don't want to do a pre-post study where you're most likely going to see a decline in, for example, utilization as an outcome, if you just follow folks over time, that's just statistically what's going to happen, then you want to start looking at a control group and saying, you know what, is it worth it to put my resources here, and maybe parse out different components of the population too and say, here are the outcomes I'm looking at. Here's my comparison population. I'm going to do my best to look at outcomes in both these populations because I really want to know if I should be putting these additional program resources I'm putting into this intervention. And the only way to really know that is to have a comparison population. Does the population have to be randomized? Not necessarily. I think that depends on the resource or the intervention that you're looking at. And I'll give a specific example. Right now, I'm evaluating a program in Santa Clara County providing permanent supportive housing for frequent users of the healthcare system, behavioral health system, and jail who are chronically homeless. And we're doing a randomized trial there. And the reason that we were able to do that was because there were only, I think it's 116 housing spots available. And we sort of decided as we were developing the evaluation framework with all the key stakeholders in Santa Clara County, you know what? We kind of need a way to ethically allocate this limited housing resource. And even though it can seem a little counterintuitive and it might seem almost cruel to tell someone, you know what, you're going to enroll in our study and then you have a 50-50 chance of getting referred to this organization that is immediately going to find you housing. In a way, it's better to be upfront with people when you have a limited resource like that and say, we're just going to use random selection. If you meet study criteria, you meet inclusion criteria, you're randomized to this. And we know that way that we're not cherry picking from the population or anything like that. And it's actually fair. So I think the other thing to think about is just if you have a limited resource and you want to see as a part of a program if providing that resource will improve the health of a complex population, that's a really great time to do a randomized trial because it's a very fair way to try to allocate that resource and to study the impact of that, the program in a very rigorous way. So I hope that answers the question.
That's really helpful, Maria. Thank you. Yeah, and it's a really good reminder. I think folks tend to be very daunted by randomized control trials and seeing it for that benefit and that sort of selling point from an implementation standpoint when you have limited resources such as housing is really useful to remind folks that. So thank you for that. Yeah. David, our next question is for you, and in just a moment, I'm going to turn to some of the questions that have come in from our audience today. But David, before I do that, we wanted to ask you about the organizational characteristics that are necessary to move into complex learning in the type of framework that you laid out for us. And similarly, what advice do you have for organizations who want to make that change?
Yeah, not a simple question. Obviously, there's been a lot of interest in learning organizations. That's a concept that's out there, learning health organizations. To me, what I have found is really on an organizational basis, it takes the right leadership. and not every organizational leadership is open to becoming a learning organization. And if you're fortunate in having that kind of overall leadership, it really helps because that sort of sets the tone for everyone else. But I think most of us operate within subcultures within organizations, and I think you can do the same kind of thing. But again, I think it's just it's basically taking this webinar and the content that we're going over and discussing it with people, being upfront with people, saying, look, you know, this is a complex population. We're going to learn as we go, and there are no simple answers. There isn't a literature where you go and pull down the specific intervention that you need for a specific population and you just plug it in. I mean, I think everybody's spoken to that. Surely there are things. I think housing is like, you know, it's one of the simplest, most straightforward things. There's a huge literature around the importance of housing, but we don't all have the opportunity to do that, or we don't. All programs are not built around that. So while there are those kinds of things, I think we just need to bring people along the journey that we're on as much as we can and recruit people to that journey within the organization. I was fortunate for a number of years to have a CEO who saw himself as a visionary and a person who wanted to do innovative things. I have seen other CEOs come and go who have less of that, but it certainly opens up the conversation within an organization. So I don't think there's a simple formula, but I think sort of advocating for it and reframing the work that we do in a way that makes people understand and taking them along the journey with you makes that opportunity much more possible.
Thank you, David. I'm going to turn now to some of the questions that have been submitted, and I'm going to direct the first one to Toyin. And we'll try to just field these questions to one individual presenter to try and get to as many as we can. And so, Toyin, the question is, can you speak to, and so I'll lay out the topic here. So in your presentation, you and Maria spoke about the importance of linking data, and we've talked about sort of the nature of addressing social determinants throughout this work. And so the question in that context is, can you speak to how we think about evaluating the fidelity of interventions in partnerships between data-rich healthcare systems and community partners who often have limited resources for data collection?
Well, that's a really interesting question. Not fully understanding the context, I'm just going to frame it in the way that I think it is intended, but maybe we can go back by text if I get it wrong. I think what you're asking is, so we have interventions, and some of them, in fact, many of them will require activity and actions on the part of community partners in order to execute on the model. So, for example, if we're linking somebody to a housing agency that is providing advocacy and referral for people who require housing, we need them to function in a certain way, and that this is challenged because most of these organizations don't have the infrastructure to report and collect on the data that we would need them to in order for us to effectively hold each other collectively accountable for the fidelity of the model. It's a really interesting question, and I think one that comes a little bit, in my view, outside of evaluation and much more on the part of implementation, because if we can't measure it because we're not sure if people can do it and we can't track it, then we have a broader question here about how do we interact effectively across healthcare and social services spaces where we are increasingly recognizing the value that community-based organizations, community partners have to play in achieving our overall outcomes. And this is where I think there is a dearth of tools for community-based organizations to, frankly, just run their organizations and track the data and the activities that they do on behalf often of healthcare agents in direct service of members that they share across or patients that are shared across both settings. Many of these organizations are running on Excel spreadsheets and pen and paper and don't have the ability to link across, to link from receipt of referral all the way through to loop closure back to the source of the referral. And so I think that there's a technical gap here that we need to solve for quickly. And some folks have started to move into that space. It's certainly something that we've thought a lot about as we sort of build out and invest in technology. So that's piece number one, is we need better tools to just track members and individual patients across those settings and to close the loop as work gets done on their behalf. And I also think that secondarily, I think healthcare institutions, healthcare providers, organizations have an opportunity to significantly improve the ability of community organizations to have visibility into the outcomes of their work and how it fits into the big picture, simply by sharing data. And it doesn't have to be raw data. It can be aggregated, it can be identified, it can be comparative data. But we have, for a very long time, I think, much to our collective detriment in the healthcare system, relied on community partners to do work for us and then never showed them outcomes and never showed them how they performed and never gave them the tools to understand how they could be better. And we certainly did some work at Commonwealth Care Alliance in this space, and I've seen other models that have also been quite successful in simply sharing comparative data across multiple community partners to show them where they stand, show them how quickly they're referring to, they're closing the loop, how quickly they're taking care of referrals, et cetera, as a way of helping them learn and a way of helping them also start to value their contributions to the overall outcomes.
That's great, Tanya. Thank you so much. And we've certainly seen that that work in primary care and in medical practice as well, the notion of sharing data to improve quality performance. And so the notion of doing the same with community partners seems like a very straightforward proposition. So thank you for that. Our next question I'm going to field to Maria, and this is a question around the comments about the importance of capturing stories in addition to the quantitative outcomes that many evaluations focus more heavily upon. And so the question is, can you discuss how to best do this, how to best capture stories via qualitative research methods as ongoing practice, particularly in an environment that otherwise heavily relies on data-driven information and, frankly, very guarded patient confidentiality as well. So, Maria, to the extent you have experience with this, with your various delivery system positions or in the research setting, would welcome your insights there.
Yeah, sure. It's good timing because I'm giving a talk on Friday where I'm actually incorporating some patient stories. So I think it can be really valuable. I mean, again, I think, David alluded to the fact that I think policymakers and folks in government love hearing anecdotes, and I think it's incredibly important because we want to get our message across, and I think it needs to accompany, whenever possible, other forms of data, but I think it's a really, really important one to include. The way that I've done it a couple different ways, you can take a qualitative approach in terms of qualitative research and do in-depth interviews or focus groups with patients to understand the impact of a program on them from their perspective, and kind of get some of the details or themes related to how your program might be affecting different kinds of patients similarly. So if they're having similar experiences, maybe with a certain type of staff or with one component of the intervention that they're feeling really beneficial, is very beneficial, or maybe they just come out of it feeling all kind of a similar way, maybe more empowered to take care of certain health issues or other issues. That kind of research can be really valuable. It's also really, really time consuming to do formal qualitative research. So the other thing that I do, and a number of my colleagues in emergency medicine will do when we're talking to legislators and policymakers, is just to include a couple almost cases. So you can talk about patient, give some initials or make up a name, give the age and some characteristics of the patient that may not, that would be kind of, compliant in terms of when you're thinking about HIPAA. It won't give too much away, but talk about what your program's done for them. So for example, a recent presentation I'm putting together right now, we have a couple slides talking about, well, here's a patient. This is in reference to a healthcare navigator program we have for frequent emergency department users in our emergency department. And, we talk about this man, his age. He had been homeless for so many years. but he wasn't actually on the radar of the homeless healthcare system because he was only coming into our emergency department, and he lived in a place and kind of slept on the streets in a place where they weren't doing outreach. So we were able to build a partnership with them, create an alert when he came into the emergency department. And I kind of tell the story of how we were able to kind of focus in on his needs and get multiple different resources to come to the emergency department to get the patient what he needed and to be placed in a temporary type of housing bed. And so that in tandem with some of the data we have from the program so far and a description of the program really kind of hammers the point home, because it can seem really vague sometimes if you don't have some different patient stories. You know, you're administering the program, so to you, it's so clear what you're doing. And, you know, you might really understand some of the benefits you're having. And look, you might have a couple fails also. And those can be potentially important stories to tell too, depending on your audience, to kind of say, here's what happened with this, and here's the change that we made, and be really specific about what kind of led you to make that decision. So I hope that's helpful. I mean, I think in summary, qualitative research, formal, has its own whole methodologic sort of framework and can be very, very time consuming. But I think it's also completely fine just to take a couple patients from your program and tell their stories. And it's really, really beneficial.
Thanks so much, Maria. I also appreciate the notion about sharing stories of the failures and learning from those as well. I think we all need to do as much of that as we can, because we're more inclined to talk about our successes and to miss those opportunities. So David, I want to hand one question over to you from the audience, and this refers to the learning framework that you presented. And the question is, if it takes years to collect data to develop what works, what evidence is presented to stakeholders at the onset to get buy-in?
Great question. So you can use lots of evidence. I think, you know, the conversation about stories is it's very compelling evidence if you use it consistently and you actually get your stakeholders to understand what you're doing. One of the things that we did early on, so we had this 3-year grant, and we was fairly sizable. We could hire 75 to 100 people, and about a year and a half into that grant, some of the people we'd hired said, hold on here, this is a grant. Am I gonna have a job in a year? Am I gonna have a job in a year and a half? And we quickly began to realize that we had to start making a really strong case about our program really early on. And what we found was that the providers in primary care who were working with our program thought it was the greatest thing since sliced bread. They just loved it. It totally changed the nature of their interactions with these complex patients. They understood what would trigger those patients, why the conversations would go nowhere. They understood how to, they rebuilt their relationships with them. And so what we actually did is we got the advocates for the program to be the primary care providers. And we went as far as to create a video of some of the leaders of the primary care community talking about their experience with this program and how it had totally changed their individual practice in clinic, and how it had changed the clinic itself in terms of just sort of stabilizing things, making it much easier for everybody to continue to do what they did on a regular basis because things weren't being derailed. So it was a combination of the stories that helped people understand the population that we were dealing with, and testimony from people who said that the program was actually changing their interactions with people. And that's sort of, you know, one of the early testing things you need as you move from prototyping into testing is to say, is this program acceptable to the people who have to implement it, and what ways does it need to change to be better? And that was one of the things that we had engaged. So we had engaged with the primary care providers who were sort of the foundation of this whole thing early on, and really worked with them. And when it was necessary for us to make the case to stakeholders, boards of directors, they were the people who made the case. They said, look, this is what makes a difference. And I had exactly the same experience early on in when we were doing putting behaviorists in primary care and in part of the medical home initiative. And again, what happened there was one of the things when we were doing this integrated care team with medical homes was the providers were saying, you know, all this other stuff you're doing, these huddles, these dashboards, et cetera, are great. We love them. But the one thing you can't take away from me is the behaviors. And that's compelling in a situation, certainly in a situation where you have a network model, because our stakeholders were mainly health plan, and the relationship with their provider network was really a critical issue. And so that's what we use. So I think you have to be creative and look at the early wins that you're getting for whom, and bring those stories forward. We did not use data. I mean, we were forced, because of the conversation that had happened sort of on day one about our program, to create this dashboard, which allegedly we were going to report, but we junked we didn't mention the dashboard as quickly as we could stop mentioning it. And we started talking about stories, and nobody was unhappy with that. And so we just kept filling the room with stories, and with stories not about the patients, but also from the providers. And that was extremely compelling. So you use what you got.
Use what you got. I love it. Advice for everybody. Thank you so much for that, David. And thank you to Toyin and Maria again as well for your thoughtful responses to these impromptu questions. I want to turn now, as we wind down in our final minutes, I want to turn back to Natasha Rosario to talk about a couple of upcoming events through the National Center in this webinar series.
Great, thanks Allison, and thanks everyone. So a couple of upcoming webinars we have. On June 14th, we're going to be doing a presentation on 1115 waivers and complex care. On September 11th, there will be a presentation from the National Governors Association on their complex care roadmap for states. And October 29th, we'll be doing a presentation on non-emergency medical transportation. And then we're extremely excited in December, on the 5th and 7th, we invite you all to join us in Chicago for Putting Care at the Center 2018. So we'll hope that you join us for these upcoming webinars in our national conference.
Great, thanks so much for that, for sharing those upcoming events, and encourage everyone to put those on their calendars. I just want to thank all of the presenters again and our partners at the National Center for the opportunity to share this discussion with you all today. Thank you all for hanging in there for a long set of presentations. I hope you came away with some new ideas and some new talking points as we think about how to not only evaluate this work, but how to discuss the outcomes achievable through these programs. There will be an evaluation following completion of this webinar. Really encourage you to take a minute to respond. We use that input to plan for future events and to make sure the content meets your needs. So thanks once again to our funders at Kaiser Permanente Community Health for making today's event possible. And we look forward to sharing future insights with you from the Complex Care Innovation Lab in the months ahead. Thanks very much and have a great day.